Is AMH always accurate? And do birth control pills or other forms of contraception affect the accuracy of AMH? So AMH is the best quantitative measure that we have. But if a patient has an AMH assessed while on birth control pills, the AMH will be much lower. So if, let's say I drew an AMH on a 26-year-old patient, and then I put that patient on combined oral contraceptive pills with estrogen and progesterone, like a typical OCP, oral contraceptive. I left her on the pill for 9 weeks, and then I reassessed or redrew her AMH level. Her AMH will be 50% lower than it previously was. That's not to say that the birth control pill has lowered egg reserve. It's lowered the ability of the test to accurately portray what the true reserve is, because the birth control pill kind of makes the ovaries sleepy and blunts or softens a little bit the crosstalk between the brain and the ovary, and that will affect how much AMH is produced. It will also affect the number of eggs that are retrieved if you start stimulating the ovaries after a long period of birth control pills. So it's not wrong to check AMH while on oral contraceptive pills, but you need to have a nuanced understanding of what the pill will do to the AMH level. All too often, I see patients who are really in a panic because their AMH has come back extremely low on the pill, and they haven't been counseled by their provider that this may be an indicator of low reserve, but it also may be just a scare, and the AMH is actually much better off the pill. So generally speaking, I might assess an AMH with the patient on the pill. And if the AMH comes back very good on the pill, the patient is in good standing. But if the AMH comes back low, we have to be careful to counsel the patient that it may just be a byproduct of being on birth control pills. And usually I want to recheck an AMH at least 2 to 3 months off the pill to try to get a more accurate understanding. As an anecdote, I have seen a patient with an undetectable AMH that 6 to 9 months off the pill had an AMH of over 2.0 because the ovaries were extremely suppressed. Now that's an extreme example, but generally you will see a large rebound in the AMH level. You also have to be careful not to be on the pill for 6 months or a year and then start stimulation, because in general you'll get much fewer eggs than you would have otherwise. So it's not wrong to do, but it really depends on the patient's goals. Most patients are trying to get as many eggs as possible within reason. And so you have to be careful about how recently the patient has been on birth control pills and how long they should be off of them before starting treatment. Other medications can theoretically affect egg reserve, namely Depo-Provera, which is an injectable progesterone-related contraception. That actually will have an even greater suppression of the ovaries than birth control pills. Also, implantable contraceptives like Implanon or Nexplanon could theoretically reduce AMH levels. In general, progestin-only oral medications less likely to have an impact on AMH, and in general, IUDs do not have an impact on AMH, whether they be hormone-producing or not. It's not terribly rare for me to see a patient in consultation who has done fertility treatments previously, and she was on the pill for 2 years, 10 years, was not taken off the pill before starting, was stimulated in IVF, and had 8 eggs retrieved. But her antral follicle count is better, and there's a suspicion on my part that the AMH was suppressed from birth control pill use. And I've taken that patient off the pill, and whereas she got maybe 7 eggs in her first IVF cycle, gets more than 20 in her second, because the suppression from the birth control pill has lifted. Now that's not every patient, that's just anecdotal, but that anecdote is not rare at all. And so, unfortunately, there's not uniformity in the field of reproductive medicine of the relationship between birth control pills, the duration of exposure of those pills, and when patients should be starting fertility treatments. And there needs to be more understanding and uniformity to maximally benefit patients and their goals.